Well, today, folks, in talking about risk management, what I'm hoping to do is several things to look at how our agency assesses risk, how we as employees can help in that area, what to do when risk is uncovered, and how to move forward, not just with outside reporting, but what we're responsible for internally as an agency. I think to begin with, when I think about risk, and I'll throw this out to you guys, I think of two main reasons why we need to do a good job assessing for risk for clients. What do you got? What are some reasons that you think we would want to do a good job with that?
So we can refer them to appropriate resources.
Okay. Okay. Well, I think the first is because we want to take care of our clients. You know, we want to take care of the people we serve. So if we're doing a good job assessing risk and making referrals if necessary, or working with that client, then we're assisting our clients, we're protecting our clients, we're making sure they're okay. And actually, I think there are kind of three now that I think about it. And the second would be, I think, to protect our staff.
Yeah.
You know, not only to make sure they're, you know, doing what's correct or ethical or obligated, but also to make sure they feel comfortable in their ability to assess risk. I think that makes them feel more professional, and certainly feel like they're doing a better job, and you know, be able to do what's necessary. You know, the last would be, and it's important, but I see the first two as more important, but is for liability purposes.
Mm-hmm.
Either to spread that liability or to remove it altogether in the event that something were to happen to a client or to someone in a relationship with that client. So those are the main reasons I see. I think too, I want to hammer away, and I'll probably say this several times today, the importance of discussing it with your supervisor. That's important for several reasons. You want your supervisor to be aware every step of the way. You want your supervisor to assist in that. And you want your supervisor to be aware. Again, as employees, it spreads the liability, you know, and at the same time, it pulls in the appropriate people to help you make those decisions. In certain instances, I think staff, if there isn't a supervisor around, which again, you should always call if there is a critical incident or an incident report that needs to be done, but certainly talking with coworkers and other therapists and other staff, you know, they may have some really good insight into how to approach those situations. Okay. Today, like I said, I want to go over just assessing risk and some different ways of looking at that, and then towards the end, kind of looking at, or second part, looking at completing critical incident reports and incident reports. I also alluded to it earlier before we really got started here that there are ways to begin assessing risk with clients even before we might actually see them. What would be some ways that you think risk is assessed even before we wind up working with the client?
Well, I know here when Shannon does our intakes, if we're doing a forensic interview, like if it's a parent who is the alleged perpetrator, they cannot, you know, bring the child, and they can't be on our side. So
Okay.
she makes sure, you know, that she tells whoever, you know, CPS or detective, whoever is referring the case, make sure that the alleged perp is, you know, not the one to bring them. They're not allowed to come in the building or even in the parking lot. They can't drop them off. So we had that happen last week.
Okay. So making sure that you know, um, is information that we have when we're making those decisions. What are some other ways that maybe before we actually sit down and work with a client?
The intakes that our team will start receiving from partnering agencies starting this week will actually have a vulnerability assessment attached to them. So, and it'll have a lot more background information than we used to get with clients originally. So we'll have some good ideas about where the risks will be for those clients before we even really meet them.
Yeah, and I think the intake department does a really good job trying to find out what's going on with the client before they come in, finding out, are there serious mental health issues? Is the client supposed to be taking meds? Are they taking their meds? Are they working with a psychiatrist? You know, are they working with any other therapist? I mean, that's all information that we need to know moving forward with a client. Again, if we know from the get-go that there's some serious mental health issues going on, then we would want to refer that client somewhere where their scope is working with, you know, folks with serious mental illnesses. Typically, it would be an agency, it might be a therapeutic agency, but that also has psychiatrists on staff, you know, those kinds of things. And then I think once the client does come in for the actual assessment, a lot of the paperwork that we give them helps us to look at managing that risk. You know, previous treatment. You know, there is for counseling, at least there is a medications list. What meds are you taking, for what, how often? You know, are you seeing a psychiatrist? Those kinds of things. So information we need to know when we sit down with clients. I think also at some point when we're sitting down with clients, for them to have an understanding that we are obligated to report certain things. You know, we're obligated to report, and I don't go into every single little thing, but basically anytime that client or someone around that client are at risk of any kind of danger, you know, we're obligated to make those reports, whether it be Child Protective Service, if it's an abuse allegation or abuse situation. The other point I guess I would make too with that is it's not our job to necessarily, at least within counseling, and I think for the most part, to investigate.
Mm-hmm.
You know, if someone comes in and this child says, the mom says he has a bruise on his upper thigh, I want you to look at it. You know, we don't need to look at it. You know, we take their word that there is something, and we assist that person in making a report, and if they're not willing to do it, we make that report. Now, if they come in and it's on their arm and you see it, of course you can factor that in, and, but we don't have to see evidence to make a report. We just need information. So, so really, when you look at, if you look at that first part of your packet, some of this may be out of order, and I apologize. I went through it last night, but I'll give you all plenty of time to find where it is. But if you look at the risk management guidelines, basically when you're talking about assessing for potential or violence and harm to the client or others, is the primary issue in service delivery. Risk can be defined as imminent harm to self or others and consists of the following: suicidal intent, opposed to ideation, violence to others with a current violent act or intent to act. Violence to others includes any physical harm, threat or injury to our own staff, our property, situations that place clients in harm's way, child neglect, unprotected sex, those kinds of things. Some of those areas get a little gray, and we'll kind of tweak that out as we talk about that. Assessment of intent is based on specific plans, previous history, previous hospitalizations, non-compliance with medications, we talked about that briefly, threats of a specific nature, absence of problem solving or the goal of safety, lack of lucidity and general responsiveness. You know, I think I would also add to that, which might be later in some of the information, but if there's a family history, you know, of mental health illness, that doesn't necessarily mean that our client has those issues, but or if there's a family history of suicide attempts. Sometimes that's an indication to us that, okay, we need to really, much like if there's a family history of addictions, we would work with that client maybe more around that issue to kind of feel that out and shake that out a little bit more. Because we know that the likelihood of, family members having those same issues are higher.
It might be good to add too, access to means, and that might be. I'm not sure specifically if that's what this point is looking at, but I know that in terms of suicide assessment, access to means to harm self also is a big piece.
Right, of course. Suspicion of risk in client or others requires conferencing with the clinical supervisor same day. So again, if there is any question, or even if there's not, you need to conference that or go over that with your supervisor, so they're aware of the situation. And certainly looking at the difference between suicidal intent and ideation, or a child, a fifth grader who says, I'm going to kill that kid, and then you talk with them and he's like, no, I'm not really going to do that, or, well, how would you do that? I have no idea, I'm just mad at him. I think as you're working with a client, obviously that child has no intent to follow through on that. And with suicide, I think kind of the same way. Now with children, I think it's upped a little bit. To me, I really err on the side of caution with children. If they're making accusations that they're going to hurt themselves, first and foremost, I would want to make sure their parents were aware of that. If they are in a school setting, that the school staff are aware of that, to get more information about that, and probably do an incident report on that. As far as making a referral to Wellstone, if it's in Indiana, or 7 counties if it's here, that would be something to kind of discuss with your supervisor to see, where that was and what safety mechanisms the family could come up with. If you've got a family that says, we're going to remove all knives, there are no weapons in the home, we're going to supervise this kid 24/7, that's different than a mom saying, well, yeah, we've got some guns in the home. He comes home after school by himself. He's there for an hour and a half. I don't really know what he does. I'm not able to change my work schedule. That's a different kind of level of concern. Duty to warn is another thing we're talking about. If you have someone who is making a specific threat to a specific person or agency, then our duty to warn is to let that person know, or that agency that might be implicated, and then also to call the police for that, wherever that will occur, or wherever that client is living, to call the police in that area to let them know, that a threat has been made. Any questions or comments, or no? Okay. Criteria for assessment include, you look at that second page, determining imminent physical harm. Client makes threat to attack self, staff, or others. Client is acting erratically. Client does not respond to verbal attempts to de-escalate. Evidence of weapons. Imminent threat to self, staff, or others. Staff will follow safe physical management policy and protocols. Abuse reporting is kind of the next piece there. Anytime we have a child that we suspect is being abused or neglected, abused either physically or sexually, we either suspect it or they let us know that that's happening. We're obligated to make a report to DCS, Department of Child Services. At that point, sometimes we are able to let the family know we're making those reports. If it's a situation where a dad comes in with a child and the child says that the neighbor has molested him, then in that situation we would immediately bring the dad in, talk with the dad about that, and I think best case scenario is while sitting with dad, have him call and the report. If dad's not willing or able to do that, then we need to make the report. Sometimes I think folks have made the mistake to say, well, they said you're gonna report it. That's not good enough for us. That's fine, and if they make the report and we call and report it, again, that's okay. But for the safety of our client and for our own liability, we need to make those reports as well. Even if the kid said, if the mom says or dad says, well, he makes these allegations all the time. Well, that is a problem. We need to figure that out. But still, with the child or with any client, it's still our obligation to report that. DCS might tell us, hey, we're not gonna investigate this. There's not enough information. We're not sure if we're gonna investigate this. You know, that's their call to make, not ours. You know, the same thing with adult abuse or active spouse abuse. We're obligated to report that. And I believe in both of those situations there are some other numbers to call, but again, we would call the Department of Child Services, or in Kentucky it's called the...
Child Protective Services.
Is it just called Child Protective Service or the Cabinet for Health and Family?
Well, there's a Cabinet for Health and Family Services and the Department for Community-Based Services.
Okay.
But when you call it the hotline, you're calling Child Protective Services.
Okay, so calling those hotlines, they would direct that to who you needed to talk to. The other thing with active domestic violence, and that we try to rule that out at intake as well. We don't, at least in the counseling program, we would not provide services, counseling services to an individual who is in a domestic violence active relationship or a couple. You know, a call may be made, but the other thing is we would want to talk with the Center for Women and Families would be an appropriate resource for those folks. If it's something that maybe happened 3 years ago and they're still together and they've been through treatment and things have calmed down, that's a different situation. But any active domestic violence, we would not offer services to that.
We do.
Okay, so your program would, what are the are there any parameters around that? Any guidelines around that?
I mean, we work with the Center for Women and Families. Usually we have 2 case managers, one with the Center for Women and Families and one with us, and we have a release of information, so we share information back and forth. A lot of times it's just trying to reduce the threat level for that client, encouraging them, you know, to get away from their abuser, encouraging them to take out an EPO. But we can't force them to do any of those things, and, you know, we can report it when it happens, but, you know, they'll leave 9 times before they leave for the final time if they're lucky enough to get out, so.
So in certain circumstances within the different programs we may, and again, most of my experience is coming from the family counseling program. So, and that sounds like an area there are specific plans within each program that you would need to talk to your supervisor about. I'm not sure, like in the CAC program, you know, your focus, at least initially, is not on family treatment of any sort. It's on bringing the child in, assessing, you know, abuse, doing forensic interviews. So I'm sure within that construct, I mean, there may be domestic violence going on, but that's not something you guys are really working with directly.
Yeah, our family advocate, the child advocate would, if she sees that or whatever, then she would give them the, my mind doesn't blank, a different possibility. Thank you, resources is what we're looking for, different resources. And then if it's something that's going on, then, you know, she'll report it to, if the child's involved, you know, to CPS.
And certainly, I know a lot of programs do some home-based work, you know, and that's, I know with our New Albany programming, with our home-based therapy or casework, we would not put a therapist in a home where there's active domestic violence going on. I remember a story, which I'll try to keep the stories to a minimum, but I worked up in Indianapolis once, and I was sitting with a client, a mom, in her home, and we were talking and doing the assessment. I kept seeing this in the corner of my eye, like this shadow going by the window. And after about 15 minutes, I said, what is that? She goes, oh, it's my husband. He's outside running around the house because he doesn't want you to be here. You know, and I'm like, oh, okay. So I immediately said, you know, I don't need to be here. I will not be here without his permission. And, you know, I removed myself from that situation. And again, that could be domestic violence, it could be anything, but if we are in a home or if we are in a situation where it's unsafe, what we want our workers to do is to do what they need to do to remove themselves from that situation. You know, that is the primary concern. Once they're in a safe situation, then they can make a report. I've had folks call me before, therapists have said, there's some active domestic violence going on, I'm seeing it. I'm like, get yourself away from that, you know, and then make a call. Call the police, call DCS, call whoever you need to do, but do it from a safe place. So I think we need to always be aware of, you know, those safety concerns and not necessarily always expect them, but just know that that's part of our job and the population that we work with. Some other information I have in here, and I think some of this would be a review, but basically there's some information in here about the indicators of child abuse and neglect, indicators of sexual abuse, and certainly that's information that you guys not only can probably already know yourself, but can share maybe with some of your families from time to time that we're working with, or parents that might have questions. I'm sure with like the different program that we had, that might even be part of the curriculum, is talking about signs of abuse and those kinds of things. So this is one that we've had for a while, and I also printed off some other information that might be helpful to you guys to kind of look through. You know, when you think about first of all, any questions or comments, insights, feel free. Again, I know some of this information. I'm not the expert on risk management, so if there's any more information, that would be great. So when we think of the agency's policy on disclosing information about or in dangerous situations, we're looking at duty to warn in particular, and we're required by law to follow the duty to warn process. It can be discharged in one or two ways. When the intended victim is identifiable, reasonable efforts must be made to communicate the threat to the intended victim and notify the police department closest to the patient's and the victim's residence, of the threat of violence. Also, when there's not a particular victim, the threat of some specific violent act must be communicated to law enforcement authorities, and reasonable efforts made to seek commitment of the patient. So I've only had a few of these in my experience. Have you all had duty to warn situations that you've followed up on, or Rashad, possibly in your past role of, being?
I have. It's a little fuzzy though, because it hasn't happened often. Because I mean, in residential, I mean, everyone lives there. But there are occasions when the kids do go for weekend visits and that kind of thing, and or are off campus for different reasons. And I think, if I recall correctly, it feels like years ago, there was a young man who made some threats to an individual in his neighborhood. And so we contacted the local law enforcement and made them aware that this individual had made threats toward this particular person. And I believe we tried to make contact with that individual as well to let them know that there were some threats made.
Okay. And, I think, again, they can be very specific, or they can be not specific, but still have intent. If a child, I had a child who was sent to me who had written a poem. No, it was a skit. And in that skit, it was somewhat obvious that the child was part of one of the characters. And one of those characters made a threat to blow up their school. The school sent that to me, and again, I was working closely with the school and with the client and with the parents. And I did not feel that there was any real danger of that. But it was kind of this gray area. So I called my supervisor, who said, well, as long as the school's aware, as long as the parents are aware, as long as we're following up, and in this case, this client was fairly depressed, as long as they're following up with a plan to get her in to see a psychiatrist and get some treatment, we just continue to monitor that situation. Now, if someone comes in and says, tomorrow after school, I'm going to blow up the school, you know, that's a very different thing, and we would need to report that not only to the school, but to the police and to the client, if it's a child, to the parents. And we probably want to pull in, if it's an adult, another adult connected to that person. I always think that's a good idea, if that's available, if the client will give that to us. So, but I believe the next form that I have, or it may not be the next one, but there should be reporting safety issues or concerns at the top, and it has some numbers for us to use. Child abuse hotline in Indiana, as well as the one in Kentucky, Adult Protective Services, if that call's ever needed to be made. And then the other piece, which we haven't talked about much, and this is something that I've never had to do a mental inquest warrant. I don't know if some of you have done that before. I think for me, and we'll go back to if you've got some experience with that, for me, because I haven't done them, I've had staff that have had to do them, I think it's always best to call the appropriate place to find out what is the process. It may have changed from year to year. It may have changed in a 5-year period. So I believe in Kentucky, the number to call, and I've got it here, would be before 3 p.m. would be the 595-4933, and they can kind of walk you through that. After 3, there's a number, and then in Indiana, which I don't think any of you are doing work in Indiana, but to call that county clerk's office, and they can walk you through that process. So before we get into maybe when we might do a mental inquest warrant, do folks have experience?
Yeah, basically, it's been even with family members that I had to, well, a member that I had to take out a mental inquest, and the person has to be a threat to themselves or a threat to others. And so it's those areas. You've got to, if it's not anything else, they won't take you.
Okay.
I was looking at Florida, which my person was in Florida, but they had like the Baker Act, which extends that. If they are not on the medication, they can also take them to a hospital and have them treated. But here in Kentucky, we're basically dealing with the mental inquest warrant that lasts for 72 hours. With some of the medication, once they get them on, it takes even longer than that for the meds to even work. So,
Right.
but they have to be a threat to themselves or to others, and that's it, basically.
And that's my understanding too. And I think there are other things that can be done that would be more positive for the client prior to a mental inquest. If that client will agree to go to see a psychiatrist, or to go to U of L clinic if they need to, or to go to an emergency room. And it's also my understanding that if that client's not willing to do that, and it's best to have a family member follow up with the mental inquest warrant. And what we can tell folks is, and some folks who are severely mentally ill aren't thinking clearly, but we can tell folks just that this is going to be a much easier process for you if you go voluntarily. That's obvious. It may not be obvious to someone with mental health issues. So I think we want to try that first, and of course we would. We want to try to draw that family member in to, if there's a child who's suicidal, or if there's an adult who's suicidal, and if the husband or wife is willing to come in, or they're with us and they're going to take that person, we could follow up on that, or if they're going to do a mental inquest warrant if they needed to, and if not, then we would need to do that in those situations that you're talking about. And I think the hold is up to 72 hours that they can hold a client,
Right.
if they agree.
And then plus they can volunteer to stay, but a lot of times they won't, and you just just get right back out and sometimes have to do it right over again.
Any other experience with? And I think that's the other reason why these numbers, if you're not sure, you know, either who to report to, or if you need to, or what a process is, to call and get that information. And also so important to pull your supervisor in as soon as possible, you know, to see what their thoughts are, to see what they think needs to happen, and to allow that person to assist you in that process. I think a lot of times we're afraid that, oh, we should know how to do this, or gosh, we don't want to bug our supervisor, or she's going to go on, or he's going to go on and on and on about this, or whatever. But the key is we want to make sure we're getting as much information as we can to keep our clients safe and to keep us safe. So don't hesitate to call, and in fact, as supervisors, letting our workers know they need to make us aware ASAP when these situations are going on. It's much more frustrating as a supervisor to find out the next day that something may have been missed, or that something wasn't maybe followed through on correctly, than to be part of that process and helping that person through that. And I'll be honest, there's times Rashad might call me and say, John, what do you think about this? And I'll say, you know what, I think this, I think this. He has his ideas of what he thinks we should do. And I'm like, you know what, I'm going to pull somebody else on this. I'm going to call Donna and see what she thinks. You know, and at that point, I'm not worried about how long is this going to take. I'm worried about, let's make sure we're covering all our bases and keeping this client safe. Yeah, this list of numbers can be helpful. Let's see. I think too, when looking at risk, and I know there's a sample safety plan we'll get into there. I'm not real crazy about that sample safety plan, but that's something we can use. But you know, it's looking at too from early on in the case. I know, like we talked about before, intake does a good job of kind of ruling some things out, finding things out. I'll speak a little bit more specifically to the counseling program, but another thing we really, and I'll say for myself, when I was a therapist, I didn't always do the job in this area that I should, but getting releases signed. If someone comes in and says, I'm working with a psychiatrist, great. Let's talk about that. Let's talk about what's going on. Let me get a release signed so I can contact that person. Again, getting more information. Having that contact if something does come up in the future. Again, if someone is at imminent risk, we don't have to have that release of information, but we need to know who the person is, or we're not going to be able to. It's best if we do have a release. The best time to get that is prior to there being some type of risk uncovered. So when you have folks come in, and I know with counseling we have specific referrals that are releases that we use to get those signed. If they've been working with a therapist, and if they were in Indiana, we were with LifeSpring and didn't really like LifeSpring, we can't go back. That was 2 months ago, and now we're coming to see you. A release signed to talk to LifeSpring. We don't have to use all the information they give us, but you know, it's information that we need to have. If there's a doctor, a primary care doc that's prescribing medication,